Welcome to Healthcare Business Growth Conversations. I'm your host, Rakesh, and today I'm joined by Dr. Daniels, a physician who made the unique leap from the exam room to the boardroom. He currently serves as president, CMO, and managing member at We Treat Fit Podiatry, a multi-location practice with clinics across Pennsylvania, Maryland, and Washington, D.C. With both a medical degree and an MBA, Dr. Daniels has been on the front lines of clinical care and now leads on the business side through managing clinics and driving mergers and acquisitions. In this conversation, we will explore his journey, the lessons he's learned in leadership, and his perspective on the future of healthcare management. Whether you are a clinician, an executive, or simply fascinated by the intersection of medicine and management, this episode is for you. Welcome. It's a pleasure to have you on the show. And I want to thank you for accepting now to appear as a first guest in our show. Thank you and welcome.
Thank you, Rakesh, for having me. And I guess that proves you have no place to go but up.
Yeah. So the first thing when I met with you, I was not fascinated by your clinic side or the way you are doing business. The one thing that got my attention was your MBA degree. So I just wanted to understand, what inspired you to get an MBA? Is it did you get it before getting into the management side, or what is the story behind that?
Well, it's kind of a development that happened over time. So I started here in my current practice in 2002 when I finished residency. And I had a senior doctor who'd been here for about 30 years by himself. And 2 years later, I was making more money than he was. So I took a pay cut and became a partner. And 2 years after that, I bought him out. And it started to grow. So right around 2008, 2009, when we hit for the first time $1 million in revenue, I started to think, wow, I don't really know what I'm doing here because, I got no business training in graduate school. I was an economics minor in college. So if you want to talk about isoquants or Laffer curves, I'm your guy, but that doesn't help you much in business. So I decided that I needed more education. So I went and enrolled in an online MBA program because I had to do it while I was still working. And I finished that in 2014. And when I got done with that, I took another look and I realized, wow, I really don't know what I'm doing. Because I wrote my capstone project on my own practice. So, and I kind of started to build from there. It's unique in the sense that it's like speaking two languages. When you go to a hospital these days as a staff member, everybody who runs the hospital, all the admin people, they're basically all business people. Whereas when I trained 25 years ago, the hospitals were run by doctors, and the doctors were the people who were the chief executives. There was a finance guy who was a business guy, but, he was, almost like the token guy in the boardroom because everybody in there pretty much were docs. So now you go in and you see that you have these two, and I think warring factions is probably accurate to say, where you have the doctors who, care about the patient care and then, really care about, themselves at the end of the day. Because again, nobody's working for free, right? So, right. And then you have the hospital business people who don't understand what caring for patients really means and are bottom line oriented because their jobs depend on it. So when you go into meetings and these two people are clashing, and they're clashing because they're not even saying the same thing or arguing about the same thing, it becomes kind of funny to sit there and, smirk to yourself about how, they can't see the other side because they're not talking about the same thing. And that's where I think this kind of comes in handy. Plus, it gets me some street cred, and, I got nice letters after my name on my email signature. So it's all the fun perks of that sort of stuff. And as you pointed out, you were interested in it. So clearly it's an interesting point of discussion to bring into focus whenever I have these conversations.
Yeah. I know that was the one thing that stood out. I'm like, okay, wow. I've never seen a physician with an MBA degree and a physician as your stature. You're well established, and then you got an MBA, and then I was like, oh wow, I was a little bit on my toes when I was talking with you during our early days of conversations. And when I put up a Google sheet with all the numbers, you just glanced, and then you got you got the story behind those numbers just within few seconds. And I was not only surprised, but I was happy because it would be challenging working with you, and also it would be fun working with you. So that's why
Well,
I wanted to.
I'm sorry. I was going to say, from business school that if you can't put it on a spreadsheet, you can't discuss it.
Definitely. So, while you are transitioning, right, from the physician, maybe whenever you decided to get your MBA, did you face any skepticism, either from maybe a self-doubt or a skepticism from peers? How did it go at that phase for you?
So I had a lot of self-doubt. As I said, I was a full-time working physician, and the program I did was competency-based. So I would come home every day after work and sit at my computer and basically write for an hour or two. And then I'd spend 4 to 6 hours on Saturday and Sunday writing to get this thing done, because that's all you did. And that was a good way for me to learn, because I learned by repetition and writing. So I got a lot out of it. I was so skeptical of my ability to do it and to finish the program that I didn't tell my wife until I actually enrolled, and I wouldn't let her tell anybody, including our kids, because I wanted to make sure that I wasn't going to, give up and quit in the middle. That's not usually in my personality, but it was skepticism on my part. And for the most part, I actually really ended up enjoying the program. It was really, kind of neat. I have a liberal arts degree from my undergrad. So, the one thing they taught me how to do was they taught me how to write. So I could sit there and write. And, it'd be funny when you'd see examples of projects and patients, people would have 2 or 3 pages, and mine was 14. So, I kind of always, if you're going to do it, you might as well overdo it, kind of thing. When I didn't really discuss doing it with my peers, I had a few very close friends who knew. Not all my friends knew. And I think more after when people found out, it was kind of again, it's like, it's an impressive thing that people think of, which, I didn't do it to impress anybody. I did it because I wanted to know what was going on, and I wanted to be able to grow my business in a responsible way. But yeah, people today look at it, and, it does get me a little bit of little higher level. I think people speak to you on a different level. We have the same thing with patients. You have to explain medical concepts to people who are not medically trained, and you want to do it in a way they understand without insulting them. And it's kind of the same thing, in the business world when you talk to non-business related people. As well as I do, is, you start talking about, quick ratios and net present values, and people are like, huh, what? I don't know what that is. Even some MBAs don't know what that is these days. But, again, I think all of school, for the most part, is basically just learning the vocabulary. Some vocabularies are more difficult than others. But, once you kind of understand, it makes a little bit of sense. And this kind of, will gel eventually into the private equity conversation that I think we're gonna talk about.
Yeah, definitely. Looking back, what skills from being a physician helped you the most in your business journey so far?
Well, I think the idea of being able to get through, professional school, for me, it was podiatry school, taught me how to not only time manage, but, budget and accomplish the most important tasks first. As I said, business school is easy because all I do is write. I mean, I wasn't studying for tests, or doing anything like that. So it was really easy for me to sit down because I could do it, as much or as little as I wanted on a given day. And, occasionally I took a day off. I couldn't have done that if I was, in one where there was, where it was exams. I think being able to do it this way is really kind of what propelled me forward. And again, every once in a while I sit around thinking I should go get a degree in finance, but getting too old for that.
Got it. So right now you are building and managing clinics. So now I just want to know the lessons from the ground in operations, right? Whenever you sit in a boardroom and it is in the clouds, but whenever you just go onto the ground and then see the day-to-day management. So now from your perspective, what are the biggest challenges that you are facing in running a clinic beyond patient care?
So obviously the most significant, I think, in any sort of medical business these days is, our falling reimbursement, and how even when we get small bumps, they don't keep up with inflation. And we are estimated 75% down from where we were if we had been indexed for inflation since the 80s, as far as reimbursement for services. So the hardest part about running a medical practice is that money is a dirty word in medicine. Nobody in medicine wants to talk about dollars when you're a doctor. I often tease that, the staff thinks there's a tree out back, and every payroll period I go pick some money off and hand it to them, and fail to understand that the patients are what pay them. And the services we provide for our patients are how we keep the lights on and how they feed their children. But you got to be very, very careful because it starts to look like you are, pushing for services that aren't there when, aren't needed when that's not the case. The case is we need to make sure that we're providing for our patients all of the things they need to remain healthy and stable. And in my case, since I primarily do wound care, to preserve limbs and lives. And that takes a lot of multitasking and a lot of different products to be able to get it there. It's not just as much as sitting in them, giving them advice and walking out the door, which we call an evaluation management visit. If you're just doing that, you're probably not only shortchanging the patient, but you're also shortchanging the practice.
Yeah, got it. So that's what fascinates me, right? You're still practicing while managing the clinics. So, can you share a decision, that improved both patient care and the financial outcomes for you?
So what we've been doing, or my whole philosophy during practice, has been to continue to bring into the practice different service lines of items that we had referred out. So, the latest thing that we brought into our practice is we started to do compression garments for patient with lymphedema or venous insufficiency ulcerations. Before we used to just say, go get them, or here's a script, or go on Amazon or whatever. And the problem is, patients couldn't find them, patients couldn't afford them, there are huge compliance issues. So we brought that in, which generates dollars for the practice, and is really helping our patients because now we know they're getting the right things and we're going over with them how to wear them and we're making sure they understand. And it's really kind of improving patient care while it's also had a positive effect on our bottom line.
That's an excellent thing to do. So, yeah, on the same line, whenever, if you see it from the clinical side, now you think of excellence. How can you achieve the excellence on the clinical side? But on the financial side, definitely, as you said, you got to find the sustainability first. So how do you balance between the clinical excellence and financial sustainability in a day-to-day decisions?
Well, clinical excellence comes first. There's no ands, ifs, or buts about it. If we don't take care of patients in an appropriate way, then there won't be any financial stuff to take care of. So, aside from the fact that, it's a moral obligation on our part to do it, clinical excellence, patient care always comes first. I tell the new doctors is provide for the patient, take care for the patient, and then we'll figure out how to make money off of it. Because again, you can't make money off of people who aren't here. So you got to take care of them or we got to close the doors. That being said is we want to make sure we're doing this in a cost-effective manner and we're being good stewards with the reimbursements that we're billing for.
So since now on the operational side and then now you're taking care on the clinical side. So now if you had to give one operational principle every clinic leader should follow, what would it be?
So when it comes to operational excellence, I always say, you have to make sure that you have the right people, because you just can't teach nice. You can teach people what to say on a phone. You can teach people how to file something. You can teach people how to operate. You can't teach nice. If you don't have nice people, you're going to fail. Nobody wants to be barked at. And, if you have somebody
Right.
who, brings their home life to the office or wears their heart on their shoulder, that's a problem. Because at the end of the day, we're here to help people. But by the same token is we're here to save limbs and lives. So, if nobody's here, we can't do that. And it's really that simple. You just can't teach nice. So you gotta hire it.
That would be a great suggestion on the operational side. Now, that's a great thing. I think you got enough of building and managing the clinics every day while working as a physician. That's a great thing. So I also know that now you are expanding. When we started working with you, I believe you got like 2 or 3 locations, and then now you are into 13, 14 locations, and then a few of them are mergers and acquisitions. And I was surprised whenever I saw when you got into the M&A side of the business. So I just want to talk quickly about it. So what drew into the M&A side of the healthcare? Was it a strategic move or did it just the opportunities unfold for you?
I would say hubris is probably what dragged me there. Thinking that I could build a better mousetrap than everybody else and trying to kind of go for it and prove my thesis. It's not easy. It is very, very, very difficult to hire and or replace physicians. If you're an accountant, okay, you can go and you can work in another state waiting to take the CPA exam. If you're a lawyer, you can work in a law firm, doing legal stuff without having passed the bar while you're waiting to pass the bar. In medicine, you have to be licensed by the state and then credentialed by insurance before you can actually make a living. So we can't just hire somebody off the street and get them to start a week from next Thursday. It takes weeks, if not months, to do that. So that's been kind of the biggest kind of factor in going through this. So that being said is it doesn't make a lot of sense, in my opinion, to open de novo locations unless it is something where there is a gross absence and basically people will be pounding down your door from day one because they have no other choices. That's not the case in, most large cities or metropolitan areas. It's certainly not the case on the East Coast of the US. So my theory has been, is if you can purchase a practice where the patient population and the equipment are already established, is going to cost less than building something from scratch. So we started acquiring practices, and with every practice we've acquired, we've had the doctor stay for at least some period of time, sometimes as short as 3 months, sometimes as long as 5 years, and just kind of grow while we're looking for replacements and while we're working in other physicians to kind of handle that volume. But I do ascribe to the you're getting bigger or you're getting smaller theory. So I always pushed to get bigger. But again, it gets to the point where it becomes a little bit overwhelming, not only to be somebody in a dual role, but to not have the entire support system in place of middle management to run the day-to-day operations. One of the most difficult things we have is supply chain. We don't want supplies sitting on a shelf collecting dust in one offices while we're out of them on another office. So, instituting, JIT type inventory control is great. And I understand it. And, some of the uppers understand it. But then, when you're the medical assistant and you're in there counting the number of cam walkers and, you don't pay enough attention and you miss 2, and then the office runs out because we think we have 2 more there than we did, it's a problem. And that's kind of, where we get with these sort of things. That being said, is the entire reason why I started this, and now I've started not only to work with private equity and corporate partners, but along with also purchasing or acquiring my own, is I need an exit strategy like everybody else. I mean, I'm not going to just one day get up and say I'm retired and put a padlock on the door and leave. Something's got to happen, because in light of some of the things that have happened here politically in the States, with people being, killed and the like, the business doesn't stop just because you're not there. The business keeps going on, and the business doesn't care. So, I hate to use the example, but the Turning Point USA, where they appointed, what's his name? Charlie Kirk's wife to be the new CEO when he was murdered. My wife is all up in arms because of that. And I'm like, the business doesn't care. Because she's like, oh, they should be in mourning. I'm like, the business doesn't care. People care. Yeah. The business doesn't care. There's business that needs to get done. There are things that need to happen, and life has to go on. Just because you're in mourning or because you're sick or because you don't feel like it doesn't mean you can just not do it. The business just goes on. It has no sympathy. It has no personality. It has no regrets. It just keeps pushing forward. So, at the end of the day, someday, when hopefully I'm living somewhere on a beach, relaxing, read my paper under an umbrella, the business is taken care of. And that's kind of what's kind of propulsed me kind of down this road, trying to get to the point where you can get to scale where somebody's actually interested in it. Because somebody like me isn't coming around to buy somebody like me. We're buying, onesies and twosies from an office perspective. We're not buying tensies and 15sies. So, that's kind of where the whole thing just kind of melts.
Awesome. It is really great nugget and then a good piece of advice that you got, that you just shared. I just want to go a little bit deeper into it, because whenever I personally think of age, the first thing that comes to my mind is culture. Because whenever you open up a new clinic, you're pretty much bringing in your culture to a different location of your new clinic. But whenever you're acquiring the existing clinic would have its own culture, its own workflow. And then how does this today change the culture and workflow for the clinicians and then for the patients?
Well, I do think that everybody has something to offer as far as things they're doing that are a little bit better than what other people are doing. So there are always things that we can learn, and we do learn anytime we have brought in another practice. That being said, is one of the reasons we're buying the practice is because it's successful. So we don't want to come in and change successful. Why? That doesn't make any sense. So there are obviously some changes that have to occur. We have to be on the same electronic medical record system. We have to use the same billing. We need to have the same thing, like the same cash collection policies and things along those lines. What I tell people is from the time the treatment room door closes to the time the treatment door room opens, I don't want to change a thing. It's successful in there. That's the stuff we want to keep going. Outside of that, yes, We'll change the advertising structure. We will rebrand. We will make sure that we have staff that's capable of handling the systems the way we need to do it. We will make sure the appointments are done correctly. All of that stuff. But I don't think if you come in and you're trying to change the way doctors are practicing, it's going to be a recipe for disaster because one, you can't teach an old dog new tricks and all physicians are old dogs. And number two is, well, why are you interested in bringing them in the first place if you just want to change them?
Yeah, that's really a good question. Yeah, you're right. Everyone has something good to bring in to the table. On the other side, what are the common pitfalls do you see with these M&As?
So, the biggest issue that we have with physicians is either the change in the electronic health record system or the required level of documentation that we do. So we run an internal audit program to try to make sure we're doing everything compliantly and billing out 100% accurately. And especially if you're a doctor and you've been there by 30 years by yourself and you've never had to have anybody check it, that can be a little bit difficult. Nobody likes to be questioned. And, the problem with medical records is if it's not in there, it didn't happen. So you can't assume or read between the lines to get information. It has to directly be stated. So, when we bring in our system and, like anything else, every EHR system now is templated. And, we make sure that we do the best we can to update our templates anytime there's changes in documentation requirements. But then physicians don't want to use those. They want to use old ones they had from before or whatnot, and they're not always in compliance. So that's the biggest integration problem that we have is just, doing that. And then sometimes secondarily, it's bringing in the service lines that we have that they've always sent out. We have a PCR lab, so we do our own specimens. Well, they've always sent them to a Quest or a LabCorp. So, now sending them to us, well, that's a little bit difficult. But then again, that's a revenue source for the practice, and it's a speed issue. And there are other issues why we have a PCR lab more so than just that. But, it's the same thing with the compression garments. It's the same thing with diabetic shoes. It's the same thing with wound supplies. These are things that we have brought in-house that a lot of practices just write scripts and send out. So, and when you do it in-house, the documentation for that has to be pristine. So, that's where this kind of templated information comes in because, they fill out the blanks in the template and they get all of the necessary documentation required to bill that. When the next audit comes, we're successful in the audit. Again, if you're not doing it, you don't understand it. If you're not doing it, you probably don't want to do extra work for it. But again, it's one of the things that keeps the lights on, and that's kind of why we're in business.
Got it. That's very good insight. So yeah, one final question on the A side. What are the key signs that a clinic or a practice is a good fit?
So that kind of goes back to, the earlier part with M&A stuff. I've spoken to a ton of stuff. And when you swim in this end of the EBITDA pool, you're not talking to BlackRock. So a lot of it is a couple of, guys who, got out of college and went to work for a Goldman or a BlackRock and, got involved with a couple deals and made, some good money and then leave. They pool their money and they form their own little fund and they come looking for SMEs to then purchase and grow. And one of the things I've noticed is they very, very much like to use fancy business terms and M&A terms that if you don't have an MBA, you probably don't know. I jokingly always say is they get their kicks for making doctors look stupid because they don't know these simple things. Well, I do, so they kind of can't pull it by me. So, so they don't know what to make of me sometimes for that. But, I think going back to the gist of the question is, from a practice standpoint, the culture matters based on the duration. So, if you have someone who's staying 3 months, it just doesn't matter. I mean, they're not going to do that much damage in 3 months anyway. You can't fix things in 3 months. The longer the doctor is planning on staying with the practice, the more that integration is worthwhile. I always, say, I really, really wish, people would be honest during their job interviews because we interview doctors and everybody comes and they wear their Sunday best and they put up their best, face forward. And, nobody comes in and says, I'm just not a nice person. No, people don't like me. Yep, sorry. They don't do that. So, unfortunately, you don't know that sometimes till afterwards, in which case that goes back to replacing them is very difficult and expensive. And again, from our perspective, we're podiatrists. There are not enough podiatrists in this country. There's only about 15,000 podiatrists in the whole country. There's just not enough of us. We have a, aging population that is growing sicker, fatter, and older. They require more of our services, and there's fewer of us to provide them. So, culture is important normally in M&As, but it's often something that we have to work through more so than seek out.
That's a great way of looking into it, especially when you're considering ACE. So I quickly jump onto now your leadership and management lessons. I know you have been in that for quite some time right now. So since you're practicing every day, maybe not every day, but still you're actively practicing. So how do you personally balance your identity? Is there an identity crisis that you go through? Or, how do you really manage it?
So I try to delegate as much as I can and be as hands off with day-to-day operations as I possibly can be. So for example, I don't interview, hire, fire, or evaluate support staff. So, we have the physicians, and then we have operations people, and we have a VP of operations who, basically speaks to, we call them administrators, but are area managers. And there's two of them and then her. So the three of them are the ones who are ultimately responsible for employee schedules and employee evaluations and hiring and firing and all of that stuff. I can't do that. I don't really want to do that, to be honest with you. When I first started, I would sit in on these interviews with, the doctor who was here, and his favorite question was to ask people to spell metatarsal. No idea why. That was just a question he asked every time. I guess if you could spell it, you got a job. I have no idea. So it doesn't behoove me to sit here and, talk to them because, again, as I said, nobody comes in and says, I'm just a jerk. So, and quite frankly, I just don't, not only have time, I just don't have the patience for it. So the hiring and firing I do is on the provider level. So, I'm responsible for the providers. So I interview them, I work out contract details with them. When there's a problem, I'm the one who has to discipline them, those sort of things. And my style in that is always very, very simple. I tell anybody that you only have to speak to me under one of three possible scenarios. Number one, we're having a physician's meeting, everybody's here, and you can't sit in the corner quiet. Okay. Number two is if there's a problem and I have to come to you. Or number three is if you come to me with something, or even if you come to me and you just want to talk, I'm happy to do it. My door is always open. I don't ask people about their personal lives. I don't, get involved in, whatever happens outside of the practice. I'm not big in telling them, what to do for patients. There are certain things that they have to do, which we've covered already. But for the most part, I try to stay away from them as much as possible for two reasons. Number one is because who really wants somebody looking over their shoulder? And, even if they think they do, they really don't. And if you do look over their shoulder, then they're going to lack the ability to do things by themselves for a long time. And the second being, patients like doctors for different reasons. And some people like doctors that are straight and to the point, and some people like doctors that chat it up like I do. There's definitively an art form to getting in and out of a treatment room in 10 minutes without the patient thinking they only got 10 minutes. And, again, that's one of those things where you can learn it. But I'm not asking patients about their spouses or their kids. It's none of my business. So if you want to share it with me, I'm curious. I like to learn. I'm happy to discuss it with you. But I'm not going to come asking you about it. I'm not. And I'm going to stay out of your personal affairs. And that's kind of that line of separation that we do where, and I don't want to imply that I wouldn't have them as friends, but they're not my friends. They're my coworkers. And, I'm okay with blurring the lines as long as it's well understood that they are my coworkers. I don't expect them to, come to my birthday party.
Right. So, as you said, the way you communicate with the patients as a physician is a type of a leadership quality, right? How does those leadership principles actually carried over into your management style whenever you just started managing the clinics? This is from the management of the clinic's point of view, not just the management of the patient point of view.
So again, that goes back to, the operational things. And again, as I say, I try to delegate that as much as possible. I'm not really part of the supply chain. I'm not really the one negotiating with benefits providers. I'm not the one negotiating with our manufacturers for different products. I have to ultimately approve of the product if we're going to use it in the practice. But, I'm not out there shopping around for copy paper. That's not my job. So delegating that to operations is what allows me to kind of have that separation. And, I always joke, I wear a couple of hats. I'm the chief medical officer, but I'm also the chief marketing officer and the chief financial officer, chief human resources officer for the physicians. So I juggle all these hats, which is why I end up working 8 days out of a week, because there's always always stuff to do. And I live in this perpetual state of fear that I'm never going to get caught up, because I never do get caught up. I'm always just a step behind what I really need to be doing.
Yeah, now when you said you are the chief medical officer and also the chief marketing officer, whenever I saw the CMO title on your LinkedIn, I really thought, like, is it chief medical officer or is it chief marketing officer? Because I see you talking about marketing, writing like not only LinkedIn articles, but also you are publishing in various publishing sites and then doing all kinds of marketing for the brand. So that's really good. So finally, for any physician considering a leadership role, now how can they step up without losing credibility as a physician?
I think that, given the consolidation we're seeing in medicine, somebody in my role is going to go away. I think it's just not practical for someone to continue to do this from a long-term perspective, especially as we bring in ambient technology, listening and the like. Part of the problem is, and I tell people this all the time, is whoever came up with the health insurance industry and developed it into what it's become today is an evil genius. Because from a business perspective, it's an amazing thing. It is set up amazingly well. From a practice standpoint, it's terrible. And I mean that because it takes the one thing that every physician hates doing, and that is documenting, and makes their entire income dependent on it. Think about that for a second.
Yeah.
It's a crazy, crazy concept. So you don't want to do it, and then you're mad when they don't pay you for it. It's a brilliant business model. And I don't have nice things to say about insurance companies from a provider side, but from a business side, that's why, United Healthcare stock is what it is, because they understand this. So it is doing someone who is, reviewing physicians and doing quality standards and, raising the bar, basically. It's a full-time job unto itself. It doesn't loan itself to, being in practice and being responsible for patient care and those sort of things. And that's why I kind of think it's going to go away. You're finding fewer and fewer people. If you start looking at physician groups, and there are physician consolidation groups all over the country in all different specialties. If there's a physician in leadership, the physician is not practicing, and that's becoming more and more the norms. I think I'm amongst the last of a dying breed in that sense. So, having a medical degree and a business degree can be very beneficial for maximizing the performance or the returns from a medical business. That being said, one of the biggest problems medicine has today is for-profit healthcare. And I work in for-profit healthcare. I'm the problem. It doesn't make a lot of sense. And if you talk to people in different parts of the world, they don't understand it at all. What do you mean you make money on sick people? So in the future, you're going to see that. Part of it is there's some of the medical schools now that have joint programs, so 5-year MD, MBA programs. And for those, I always wonder whether or not this is going to become a business track where they don't go into a medical residency to learn a specialty or an area of concentration, and they just go off into business once they finish medical school to work on medical startups, tech startups, ambient listening, AI, those sort of things. But when you have this technology, it tends to take something you don't want to do and do it for you, which means it makes you a little bit lazier because you're not reviewing it as much. And again, I have a whole list of stuff my AI has said that makes no sense. I'm going to start a Twitter handle, stuff my AI says, but unless you're reading it, you're not. And it's so easy just to hit, good, check, and not read through all of it. And again, AI does hallucinate. I think one day they're going to find there's some, virus that, some sort of drug that AI uses, and every once in a while it gets infected by it and starts blurping out, ridiculous answers.
That's crazy to hear, and it's scary as well. So since you're talking about the future, I just and also you said, your role is not sustainable. So then, where do you see the role of physician leaders evolving in the next 5 to 10 years? And then, one part you said, completely need to step out from the practicing phase to just step onto the boardroom. Is that the way to go, or do you see them evolving in any other way?
I mean, again, I think the way it's going to evolve is you will have business almost like you have as a medicine specialty. I know lots of people who have gone to medical school with no intention of ever clinically practicing. And for that, to then do a residency slot or take up a training slot for somebody who wants to provide patient care seems counterintuitive to me. So I do think it's going to become, instead of going to internal medicine or going to surgery, you go to the business track. Again, the business track also allows you to, do a lot of research-oriented biomed, because again, you're going to understand the economics behind it and you have the science background to understand it as well. As I started with this, it's, the people running hospitals this time don't really understand what patient care is. They're looking at their Press-Ganey scores and saying, oh, you're doing this and this and this. But at the end of the day, they don't really understand what it takes to get there, especially when patients are scared or upset or we're given bad news. It's not as easy as it looks to be able to, stand there, because you can't walk in and say, I'm sorry, you have cancer, you have 6 months to live. Thanks very much. Here's your bill. It's more than that. Not that there aren't doctors that do that, but it's more than that. And unless you've had experience on the patient care side, it's really hard to understand what these business aspects and what the ramification of these business choices really are. So, I do see, physician executives, basically on a track for that, as opposed to clinicians. And again, that's also problematic because there's not enough medical school seats anymore. And, again, older, sicker population, not enough doctors. And if we have doctors that aren't going to be practicing physicians in some way, shape, or form, and that includes the ones that are also, going off into research, we're all suffering because of it. So, it takes more than just a medical degree to understand how to run any sort of medical business. And that's why I think it's going to become kind of its own specialty.
Got it. So as you said, then there is a huge gap, and then there is a huge scope for the medical business side of things for any young doctor to think of. I'm just curious to ask this question, because I asked you this question long back, but I want to reiterate this question. Is the more and more clinics that you open, either a new clinic or you just go and acquire a new clinic, what is the identity that you want to get into? You as a leader, leading the We Treat Fit Podiatry brand from the front, or do you want to be in the back end and then just be the We Treat Fit Podiatry, evolve as a brand itself one day? Because that is really, because you are the person, you are the face. If I just remove you from any communication, We Treat Fit has no face. And so how do you see it evolving in the future?
Well, I sometimes I do think it depends on what day of the week it is. When it comes to podiatry, there are lots of small, finite, intricate things that we have to do. Where, as I get older and my hands start to hurt, are becoming more and more difficult to do physically. So, doing fine manipulative surgery, when you start operating on toes, it's not that the surgery is difficult, but, you can't be slashing and burning down there. There's too much stuff you can cut. So, you have to have these kind of finite skills that, I think your skills will diminish with time. So, using that logic, I would say that, I would find my way no longer to be doing wound care at the end of my career, or surgical care, practice care at the end of my career, and, more into management at the end of my career. That being said, as time has gone on, my clinical time, which had decreased, is now increasing again. And I'm doing more and more and more clinical time, just because that's what we need to do to be able to service our patient population, and the patients come first. So, for myself, the idea is, this was my exit strategy. I would first stop with patient care and just do business side for a while. And then when I was done with business side, I would just retire and go off into the sunset. Again, now I don't really know. Right now, I can tell you doing both is, an easy way to burn out very quickly. I am completely aware and understand the concept of physician burnout and what happens and why. That being said is I'm stubborn enough not to quit. So I just keep going. I'm like the Energizer Bunny of podiatry. I just keep going and going and going. And that's what I'll do until it gets to the point where either I don't want to, or I can't, or maybe I could afford not to. But that day's not tomorrow, I can tell you that.
Yeah. Got it. So is there anything else that you want to share that I didn't cover that you think you want to share?
I do think the idea or the concept of starting practices from scratch, especially as a solo practitioner, is virtually impossible these days. People, it's so expensive to do an upstart of an office when it comes to the equipment you need and the staff you hire and those sort of things. Plus the necessity for the business background makes it hard. 30 years ago, people routinely got out of residency, hung up a shingle, and practiced for 30 years. Those days are over. The costs involved, the upkeep costs and the back end costs are so high these days that it's very, very difficult unless you have an established flow of patients to really kind of keep a practice going. So, that being said is when we interview residents coming out of school these days or out of residency, none of them are really looking to start a practice or buy into a practice. They're really just looking for jobs. So we're hiring labor, which wasn't the way it was when I was there. You went, you got a job, you became a partner, and, you sold to somebody else years down the road. And again, that doesn't happen anymore. So I do think the only people who are going to remain in solo practice are doctors who buy established practices from an older guy. And those are becoming fewer and farther between. I mean, even podiatry, which has always been very fragmented with lots of mom and pop businesses and lots of onesies and twosies, is starting to grow over necessity because you have to manage costs and you need to dollar cost average everything. And you just can't do it by yourself. Not to mention is you can't ever really go away or go on vacation when you're by yourself. There's nobody, you got to find someone to cover for you. And that's one of the things we're having partners, they cover for me. I don't have to worry about going away. My patient's not getting care because, when I come back, if something went wrong, they got to answer to me.
Yeah, got it. That's a great piece of advice. And I think you're the knowledge powerhouse. Like, I can get more stories out of you. But for today, I want to stop here. But definitely, I want to have you telling more stories in the future. Definitely, we should have more conversations in the future. Thank you, Dr.
Absolutely.
Daniels, for featuring on our first show. Thank you for sharing your journey from medicine to management and to mergers, right? For our listeners, check out Dr. Daniels' recent LinkedIn article, Bridging Medicine and Management, for more insights. This has been Healthcare Business Growth Conversations. If you enjoyed today's episode, follow the show and share it with someone passionate about the business of healthcare. I'm Rakesh, and I look forward to continuing the conversation in our next episode.